Unit 5, Methods and Techniques for Midline and PICCline IV Therapy. In this unit, you'll notice there's going to be a lot of commonalities between what we do with our peripheral IVs compared to those with the PICC and the midline. I'll be highlighting mostly the stuff that is going to be different, but you'll see there's going to be a lot of overlap. Some of the reasons why we use central venous therapy. Obviously, the drugs and solutions are infused directly into a major vein, and we'll talk about where that tip is going to be for the PICC line as well as the midline. But generally, doctors are going to order central lines when the patient, if they don't have peripheral IV access, whether they're severely dehydrated, they have burns all over their bodies, or their systems are starting to shut down, and that blood flow has been shunted away, and so it's unable to, you're unable to get that access. If the patient needs a large amount of fluids infused, especially quickly, we're going to be looking to a central line. If the patient requires multiple infusions, if the patient requires long-term infusion therapy, many times if a patient has antibiotic therapy, let's say for 6 weeks, that patient isn't going to be staying in the hospital for that full 6 weeks. They'll be going home with the central line, and either they'll have somebody come to the house to do the administration of antibiotic, or they'll be taught themselves how to do the therapy, as well as they could possibly be coming in for care and maintenance at a facility. If the patient is going to have irritating medications or chemotherapeutic solutions that would irritate the vein, this is a good alternative for that. If the patient is going to need TPN or total parenteral nutrition or other high osmolality solutions such as lipids that would not be able to infuse through a peripheral IV, that's when the doctor is going to order a central line. It's best to look at central line as the first thing with these factors to take in consideration as opposed to a last line. So what I mean by that is if you know your patient's going to have antibiotic IV therapy for a long amount of time, you're not going to want to just do IV therapy for, let's say, 5 days that he's there, and then all of a sudden before he goes home, put it in. So you want to be thinking about that, what their diagnosis is, and again, looking at medical history and what we hope to accomplish with this access. Some of the benefits for central line are obvious: access to central veins, rapid infusions of medications or large amount of fluids. You can draw blood samples from central lines, which is great, especially for that patient who has frequent blood draws or lab draws. Also used to measure central venous pressure. Reduces the need for repeated venipunctures, as well as reducing the risk of vein irritation. The risks are a lot higher for complications. The complications are more serious with the central line, just for the fact that it is that central venous access. You have a risk for a pneumothorax, depending where it's inserted at. Sepsis, as well as thrombus formation. You might have some perforation of a vessel, as well as adjacent organs. The PICC line, midline, or central lines do require more time and skill to insert. This is not something just your floor RN is able to do. It does cost more than peripheral IV as far as the insertion, especially if you need somebody specialized or an advanced practice nurse or a doctor to insert, as well as the supplies. You have a greater risk for air embolism, and we'll be talking about that later on of things you can educate your patient on and have them do to help reduce that risk, as well as having a greater risk of infection. Obviously, since this is going right into that main venous flow, blood flow, especially right to the heart, your chance of a more severe infection or sepsis is a lot higher than peripheral IV access. First, we're going to talk about PICC lines, and then we'll kind of talk about midlines and where they're comparable and where they're different. For the PICC line, this is one of the most common central lines used, or central venous access devices that is used. The tip of it is going to rest in the superior vena cava. This is generally used when patients need the infusions, again, of caustic drugs such as antibiotic therapy or chemotherapeutic agents. Many times it's going to be used when the patient has a chest injury, trauma, COPD, or other respiratory problems that might make it difficult to put that central line in their chest. It's used most commonly with the following conditions. Those patients who do have AIDS, cancer patients, those who have recurrent infections, because again, remember we said having a PICC line does reduce infection rate because you're reducing the number of insertions. Those with sickle cell anemia, women who have severe morning sickness and they need to stay hydrated, those who are receiving analgesics or antibiotics, blood products, chemo, immunoglobulins or immunotherapy, those who are receiving opiates, and again, that total parenteral nutrition or TPN. The PICC line comes in different configurations. We either have our single, double, or triple lumen configuration. Obviously, the single one is going to have a single access, where the double is going to have 2, and the triple you're going to have 3. Sometimes they have guide wires to help guide them in, while others don't. The patient, obviously the physician or the one ordering this is going to have to assess that patient does have a large vein and have that access, because generally they're going to be going in the arm, whether it be the antecubital or a little bit further up. The gauge of the catheters for PICCs range anywhere from 14 to 24 gauges in diameter, and the tubing length is, or the actual catheter length, I should say, the sheath can go anywhere from 7 3/4 inches to 23.5 inches in length. Obviously, it's just going to depend on where they're inserting it. So you don't want that tip to go past that superior vena cava. That could cause arrhythmias and other cardiac issues for that patient. One thing to know, and I put it in here, is that when you are flushing PICC lines, central lines, midline, specifically we'll focus on the PICC and the midline since those are the two that you'll be able to flush, so your expanded scope. It is important to know not to use anything under a 3 ml syringe used to flush it or maintain it or do anything with it, especially a 1 ml TB syringe. The pressure could damage that catheter sheath and blow that PICC line. So pretty much the standard is, I like to say standard is 10 ml for flushing for PICC lines and midlines. So always, always, always remember that, because the last thing you want to do is hurt the patient or do something with the PICC line that you're not supposed to. If you refer to page 90 and 91 in your book, it has the different pictures of the single and double lumen, just to kind of give you an idea what it looks like as far as defining the different parts of the PICC line. There are, and also on page 91, you have a picture here of the peel away contamination guard, and I want you to notice that they have staggered infusion ports. So if you were to look at a PICC line, and when you look at one in the skills lab, you will see it's not like a regular catheter sheath where it just has one opening for the fluid to go in. This catheter sheath is going to have many different holes, and depending on if it's a single, double, or lumen is where it's going to be, the fluid's going to be coming out of that. So something just to look at and be familiar with. Many times midlines are erroneously called central lines, and I know I included it in the central line lecture, but the main thing with the midline catheter is it does not extend past the shoulder, and we discussed that in Unit 3. The tip does not rest in that central venous circulation, so hence it's not really a central venous access device. However, I put it in with this because your dressing change and the way you flush it and maintain it is like a central line as opposed to your peripheral IV line. So always remember that the PICC line is going to be, that tip is going to rest in the superior vena cava, and the midline is not going to extend past the shoulder. But again, your dressing changes, your flushing, that is going to be the same as with central lines or your PICCs. Some states do allow RNs to initiate and DC the PICC or midlines. They're going to have specialized training, whether it's facility training or if it's their certification training. However, this is not included in your expanded LPN scope of practice. So in the event that an RN tries to delegate discontinue of a PICC line or midline to you, very important to know that that is not included in your expanded scope, and that would be considered practicing out of your scope of practice. Prepping the patient for a central line or a PICC line or midline is pretty much the same as you would with the IV. It is going to require more education and knowledge for the patient, especially if this is going to be something that the patient goes home with as far as care. We're not going to get into home maintenance for the patient, that patient education, but it is important that you do know about it so that if the patient does have some questions for you, you're able to answer it. The person who will be inserting the central line is going to be the one who is doing most of the education for the patient, because they are going to have to sign a form. I cannot believe I can't remember it. They're going to have to sign the form just that they agree to the procedure on this. So very important that that patient is educated by that person, but yet you still need to know in case that patient has any questions after the main person leaves. With these procedures, it's going to be sterile conditions, so you're going to have the gowns, the masks, and the gloves. Many facilities will already have a prepackaged dressing change kit as well as a prepackaged I want to say introducing set, but the prepackaged insertion set. But the person who's going to be putting this in will gather those supplies. They may ask you to get them some backup supplies. You'll be educating the patient on bedside positioning, depending how they're going to be putting it in. If it is going to be at bedside, they can put in PICC lines at bedside. They could also do it under x-ray as they're doing it, just to make sure that that tip does not extend past that superior vena cava. Same with the midline. They're going to want to see that. If it isn't at bedside, many times they're going to send the patient down to x-ray before they even start administering solutions and fluid to make sure they have the correct placement. The patient is going to get a local anesthetic, so they're going to have lidocaine or what have you injected around the insertion site. So that part might sting. The actual insertion should not hurt. The patient may feel some pressure, but again, this is where supporting the patient and helping with their anxiety is key to their comfort. One thing that we'll be talking a lot about, especially when you do any manipulation or cap changes or flushes, is to have that patient do the Valsalva maneuver. And what that's going to do is that's going to help put some pressure on that, so you'll have a decreased risk of air emboli being introduced in that tubing. And if we all remember from nursing school, Valsalva maneuver of kind of like bearing down or holding the breath. When this is also being inserted, most likely the practitioner who's inserting it will have the patient put a mask on, and that's just to help prevent any germs. Let's say the patient starts coughing or talking. Sometimes it's not enough just to have the patient turn their head to the other side or the opposite side of where the insertion site is, but it's just a safeguard to have, as well as if you're assisting, it is good to have a mask on as well. Through your expanded scope of practice, you'll be able to flush the PICC and midline sites with, again, the saline and heparin, as long as it is prepackaged in a syringe, either from the manufacturer or it has been drawn up and labeled by an RN or pharmacist. Very important that the label is proper, that the label actually has what the medication is, the date and time it was drawn up, and the amount that is in the syringe. So it can't just be a piece of tape with the word heparin written on it. It does have to be properly labeled, free to use. You'll also be able to do the dressing changes for the central lines, the PICC lines, and midlines specifically. And the dressing changes for both of those are going to be the same. And again, we'll discuss it and go through it on your skills checklist in another lecture. You're also going to be responsible for monitoring the patient while they're having this therapy. So very important that you know what to look for, because there are things, since you are in that central venous access, that central venous or central vein, there are different things to look for than what you'd look for with the peripheral IV, specifically infiltration. You're not going to see the type of infiltration that you're going to see with the peripheral IV line, with that vein being so close to the skin. One of the things you are going to monitor specifically for the PICC line, since that tip is located, again, in that superior vena cava, is possible arrhythmias or cardiac status. If that patient all of a sudden feels like, if they're not hooked up to a monitor and you cannot visually see it, but let's say the patient starts complaining of it feels like their heart is fluttering, or that their heart just seems to be beating weird, that might be a situation where the tip has somehow was maneuvered or moved a little bit further than it was. Even though PICC lines are, you'll see they're sutured in place to help decrease that risk, it still can happen. So when your patient does start to tell you that they have these symptoms, it's important that you notify the RN and go from there to see if she'll call the physician. They may order another x-ray just to see again and verify where that tip is. I personally have had this experience, but I only seem to notice it more with manipulation, like when my PICC line was being flushed with saline. And I don't know if it's because the nurse was flushing it too fast, but anytime they would flush it, I would all of a sudden, I would just feel like my heart was beating out of my chest, and my rhythm felt so irregular, and it was just the most bizarre and very unsettling feeling. So when you do go to flush it, we'll teach you how to flush it in a pumping motion to do, but you might want to kind of go slowly. Another odd side effect of central lines is, since it is directly in that central venous circulation, is that you will notice patients will complain, or if you've ever had a central line, that immediately when you start flushing, your patient will complain of a metallic taste in their mouth or a salty taste in their mouth. And it's something that will dissipate after a few minutes, but it is unpleasant, and especially if you have somebody that's continually having those lines flushed with a normal saline. Sometimes I will, if possible, if the family member, and if it's okay with their diet and all that and their condition or their diagnosis, I will recommend sucking on a lemon drop. That lemon seems to take that taste away. And in fact, that's what I did when I was getting my PICC line flushed. Just before they'd flush it, I'd pop a lemon drop in my mouth and suck on that while I did it. Because it is very uncomfortable. It feels like you're sucking on a nickel or a dime, and just saying that right now kind of makes me want to pucker up thinking about it in my mouth. Not very good. Some of the other things you're going to be monitoring are the sutures, and that comes with the site too, to make sure those sutures are still in place. If the sutures, for whatever reason, come undone, that is something to be very concerned about. That's an urgent matter because that sheet, that catheter could have migrated or it could have come out. So very important that you're watching to make sure that those suture, that site, the integrity is maintained. Some facilities, and this is a good also rule of thumb, is they actually measure around the arm. Let's say if it's an antecubital, they have a certain spot, depending on the insertion of the PICC line, where they measure, and their facility policies may range, but what I've seen is with every dressing change, they measure a specific part of the arm, the diameter around the bicep, for instance, to note any changes. If you have any infiltrations, you're going to see the more subtle changes with the measurement, with the tape measure, as opposed to just visually seeing the swelling or edema. But with that, it's important that your facility, or that you follow exactly what spot they are measuring. I've seen nurses use a permanent marker and put dots where you can kind of follow the tape measure around, just to make sure that you're measuring the same spot. Because we all know if I measure maybe 3 inches up than what everybody else has, I'm going to have a completely different reading and measurement. So important that, again, you follow your facility policy and you follow it correctly and measure at the same spot each time. For monitoring the site, generally, again, this might vary from facility to facility, but usually they'll change the dressing after the first 24 hours. And it is going to be like a Tegaderm, a transparent dressing, so you'll be able to visualize the site. We'll talk about some other things in the skills lab as far as using, and I cannot remember the correct term for it, but almost like the little antibacterial or antifungal discs that they'll put underneath the dressing changes. You'll see them with a little cutout, almost kind of like I think of tracheostomy or other dressings where they have kind of the cutout that can kind of wrap around where the insertion site, where the tubing comes out. So we'll be talking about that. But one thing to always know with PICC and Midline is you are using sterile technique with the dressing changes. And most places will have a kit that has everything you need. It has the sterile gloves. It has the mask for you to wear. Again, just with like insertion, it might be a good idea, and your facility policy may mandate that you also have the patient wear a mask during these dressing changes, because same with insertion, you're still going to have that increased risk of infection. The area of insertion, obviously, we're going to be looking for the same things like we do with the peripheral IV. We're going to be monitoring for redness, any drainage at the site, any swelling, and we're going to be monitoring that at least every 2 hours, or excuse me, at least every shift. So important that we are keeping track, and then we're also documenting those assessments that we do, because again, if it's not documented, it is not done. I also want to mention here really quick is that generally the dressing changes, your facilities might have them every 72 hours or every week. That's also going to go with the flushing too, depending on how much it is being accessed. We are going to be flushing before and after antibiotics if it's intermittent therapy with that. So those are things you're going to be keeping in mind. Obviously, your central line is not going to require as much flushing care as your peripheral IV site. The documentation that we're going to be doing with insertion as well as with dressing changes, it's going to be the same as a peripheral IV documentation. However, we will be definitely charting the length of the catheter. We still do with the IVs, however, it's definitely going to be longer. We're going to document if, let's say, we had blood samples that were drawn from that IV site. We're going to, and that's something that the RN will be doing that is outside your scope of practice as an LPN, but just something to note. We're also going to be documenting the length of catheter outside the site. Your facility policy may not have that, but this is also a great way to measure if that tubing has migrated. So take literally the tubing that is outside the body from the site of insertion and measure it, and then document exactly what you're measuring and what the result was. That would be a good thing to also monitor, such as you're doing with the other cares. I want you to refer now to page 108 regarding dressing changes. For the central line dressing changes, obviously after you assemble all your equipment and you've educated your patient on the dressing change, I think it's a good idea to tell the patient step by step what you're going to do before you do it as well as while you're doing it. You're going to wash your hands and you're going to place the patient in a comfortable position. You're going to prepare that sterile field. Again, this is going to be a sterile dressing change. You're going to open the bag and place it away from the sterile field, but still within reach. So this is going to draw upon your knowledge that you learned from nursing school of creating a sterile field and not contaminating it. Obviously, if you contaminate it, you'll have to start over. We're going to put on just regular clean gloves when we take off the dressing. However, after we remove that old dressing, that's when we're going to remove our gloves and wash our hands if we can, and then put on our sterile gloves. So once we put on just regular gloves to remove the old dressing, we're going to look again for any signs of infection, any drainage. If there's any possible questionable drainage, they may want to culture that at the site or off the old dressing. If not, you can discard the dressing and gloves in the bag. Make sure that you obviously dispose of it if there's a lot of drainage, that you dispose of it properly according to your facility policy. If you do notice that there is some smell or suspicious drainage, that you do contact the physician for that. Okay, and then depending on where the patient is having it inserted, you may have to put them in a special position. But you shouldn't too much for the PICC line or midline as opposed to a central line, where sometimes you have to put them in reverse Trendelenburg and that type of thing. Okay, so now we're back to after you have inspected the old dressing, the signs of infection around the insertion site, and that type of thing. We're also going to now get rid of that, and we're going to wash our hands and put on our sterile gloves. We're then going to clean the skin around the catheter with the chlorhexidine using a back and forth or side-to-side motion. And your package, you'll have the swabs in which you'll clean with on that one. Again, it's the same with peripheral IV. We're not going to blow on it to dry that prep to the skin. We're not going to fan it with our hand. We're going to let that air dry. Then we're going to either redress it with our transparent dressing, or we're going to put that little, I'll call it a wafer, but it's a little round, kind of like, I almost kind of say it's like a gauze, but it's a little bit more thick than that. We're going to do that, and then we're going to put on the transparent dressing. If the access device isn't sutured to the skin, we're going to use a catheter securement device or sterile tape or sterile surgical strips to help secure it. We do not want to put that tape underneath your transparent dressing. Any securement we're going to do above that transparent dressing or tegaderm. We're also going to make sure that we do not put anything directly on the catheter insertion site. After we get done with that, we're going to write the dressing. We're going to write on the dressing with the date, the time, and our initials, as well as discard all the items that we used. Make sure that we discard them properly, and then we're going to reposition that patient comfortably. So it's pretty much the same as what we do with the peripheral IV site. However, the only exceptions would be is it is sterile. We're going to take a little bit more care to make sure that it is secured correctly. As well as, and I can't remember if I mentioned this with the peripheral IV, but we're always going to document the patient's response to the intervention. So meaning after we're done with this and we documented dressing change, we're going to document patient tolerated well, or what the patient's actual response was. While we're doing this, though, we're going to have, especially when we're doing a cap change, and we're going to do, the caps are at the end of the lumens, and that's what we're going to use, like the Luralock to screw on IV tubing, or we're just going to leave the caps on. Those are going to cover the lumen, because normally then they're just open. So we got to put a cap on it to close it off. Generally, the caps are changed when the dressing changes are done. Also, it is done if, let's say, if it gets bloody, if you have a nurse that is accessing it frequently for blood draws, you might have some blood that ends up in the cap. So it is a good idea, and some places do have a policy that says, you know, after blood draws that you change the cap. We'll talk about that, and we'll be doing that in our skills lab. But while you're doing that cap change, you would have the patient do the Valsalva maneuver, again, to bear down, just put extra pressure on that to reduce the risk of air emboli. If you turn in your book on page 112, we have some information on documentation. It's at the bottom part here again. Always record your assessment findings and interventions according to your facility policy, and that just goes back through what we talked about with the peripheral IV dressing changing documentation. For central lines, you'd include if you change that cap, on that one, any flushing procedures, any blood samples that you obtained. We'd be documenting that. Something that I did want to mention on page 113 at the bottom there, special care. Besides doing just a routine care that you're going to be doing for your central lines, it's also important to make sure that you're checking for possible any damage or kink catheter, any fluid links you might notice. Always tailor your interventions to meet the special infusion requirements, obviously the pediatric, elderly, and home therapy patients. You will not be dealing with pediatric unless they're over 12. You will not be doing any therapy in the home, so that part can be excluded. But major potential traumatic complications, including the pneumothorax or systemic complications such as sepsis, always know in the back of your head of how you're going to manage that if that comes up or if that happens. So keep all those things in mind. Very important. Kinks can happen with the catheter underneath the skin. They can find these through x-ray. So again, if you go to flush, it's not uncommon for, let's say if you have a triple lumen, for one of the lumens to not flush well, or it is common for them to stop giving you blood return. So let's say you're drawing, the RN's drawing for blood. It is important that you document when this happens. And the lumens are going to be different colored, so you can say red, brown, or blue. You'll also notice in the documentation that an RN will document or should be documenting which lumen she drew blood out of if there's multiple lumens. So important that you flush all of them and that you use heparin if need be according to your facility policy. But if you are having problems flushing a line, do not force it. Again, in the skills lab, we'll talk about correct technique when you go to flush it, because it is a little bit different. You kind of use a little pump technique for the pressure. But if you have a lumen that will not flush, do not force it and let the RN know. That doctor will then decide the next step, whether do an x-ray to see if there's a kink or if there's something going on. That doctor is the one who's going to be writing an order to check it out. So that type of thing is considered emergent, to where you would contact your RN or your supervisor to let them know what's going on. Pages 107 and 109, there's some information on changing solutions and tubing. Same thing applies to your PICC line and midline as far as tubing and solution changes. So we're not going to go too far into that. But something that I just want to say obviously is changing your IV solution every 24 hours and tubing every 72 hours is pretty much a standard practice. Your facility may mandate it to be changed more often, but then again, this is important that you are labeling the tubing so that you can be sure that that is done. When you do that tubing change, make sure that you maintain a strict aseptic technique, and we'll go over that again in the skills lab. You don't need to wear a mask unless there is a contamination risk. For example, if you have the flu, which you shouldn't be working, but if you have any type of respiratory infection, that type of thing, you want to be very careful. On page 9, it gives a little bit more information on flushing the access device. And again, with any flushing, whether it be the peripheral IV, PICC line, or midline, we are going to document with what we flushed, what size of syringe, and what we flushed with. On page 111 and 112, here's some steps to flush your catheters. When you flush it, you're going to put on gloves. You're going to clean the cap with an alcohol swab using at least a 70% alcohol solution. Again, you're going to clean not only the top, but the sides. You're going to allow the cap to dry, no blowing on it, no fanning it. You're going to wait for that to dry. And then you're going to flush the recommended or the prescribed type and amount of flush solution. To prevent blood backflow, blood backflow and possible clotting in the line, What you're going to do is, these are the different steps for the central line, is you are going to maintain positive pressure by keeping your thumb on the plunger of the syringe, and you're going to engage the clamping mechanism on the access device. The lumens will have a clamp on it for the most part. Some of them don't, and that's where you can just use kind of like a pumping motion when you flush. If they have a clamp on it, you're going to clamp it off just like you would with the IV lock on a peripheral line, but you're going to do that as you are flushing. So right at the end, you're going to keep that thumb on that plunger for that pressure, and then you're going to clamp it before you unscrew the syringe or withdraw the syringe. Again, here's some more information on changing caps. The caps are Luer lock. The thing with this, you might see some nurses, and I have seen this done, where they'll pre-flush the cap. So they'll grab one of their flush syringes and put a little bit of saline on the cap before they put it on. But really, evidence shows in manufacturers that they contain such a small of an empty space that there's really no need for it. But follow the manufacturer's directions, because each cap might be a little bit different, but definitely check with your facility policy on that if you are concerned or if you don't know. As with anything, we've learned this, and again, I've mentioned it, I think they're up to 8 rights now. But with anything you do, whether it's a dressing change, medication, administration, changing IV bags, you need to make sure you have the right medication or solution, make sure you have the right dose or flow, make sure that it's the right patient, it's the correct time, you're doing the correct route, and that you document it correctly. We'll go ahead and we're going to move on to the skills checklist of things to be aware of, and you have this available in your syllabus. But for the skills checklist, when you're being checked off, these are the steps in which you'll be evaluated on. Routine steps, which basically is listed for every procedure, which you should already know inside and out by now since you've been practicing as a nurse. But we're first going to check the physician's orders for specific information. We are going to identify the client and use general rule of thumb is 2 patient identifiers, so asking their date of birth and their name. We are going to check for allergies. We are going to assemble our proper equipment for the specific procedure. We're going to provide that client education as well as document it at the end. We're going to position the patient as needed for the specific procedure, and then we'll wash hands appropriately. Each procedure, again, will have a list of steps. So for this first one, in Appendix F, right here, initiating the IV therapy, again, with your expanded scope, you can initiate an IV with a peripheral catheter that is 3 inches in length or less for an infusion or peripheral lock. So obviously in these steps, your steps may be a little bit out of order, and that's fine as long as you do the ones that are specifically needing to be in order, such as cleaning the area thoroughly with an antimicrobial solution. We're obviously going to want to do that before we start inserting the catheter. But obviously, if we maybe inspect the catheter for defects and then, we do something else that step, that's okay if it goes out of order. But obviously, we're going to apply the tourniquet, locate the vein, that's fine. So just make sure that you practice these steps when you're in the skills lab. Appendix G, and then, let me stop here. Routine steps for after the procedure, and this is going to apply to basically all of them. We're going to discard our gloves, our equipment. We're going to wash hands. We're going to recheck the entire IV in site, assess for any complications. Again, dispose of any used equipment properly, and then document appropriate data per procedure on the client's record. So, moving on to G. This one is change the fluid container and tubing for a peripheral midline and PICC line. Those are all going to be the same. Again, we have our routine steps, which we talked about before. We're going to set up our equipment. We'll be doing this in the skills lab. We're going to prime the tubing, and you'll learn all about spiking the bag. And then our routine steps after the procedure, you notice it's the same as before. Appendix H, you're going to learn about administration of antibiotic through a piggyback for peripheral, midline, and PICC line. Again, these are going to be the same, so you don't need to do it 3 times to demonstrate it. But we have our routine steps listed again, and then our procedure. And you'll be learning how to piggyback or use a secondary tubing for the antibiotic. Again, our routine steps after procedure are the same. Appendix I, converting a peripheral intravenous line to peripheral lock. So you will need to demonstrate, let's say they have a continuous infusion going and the doctor has ordered that it be locked off and we stop that infusion. You'll learn how to withdraw that tubing and put a lock on that IV. Again, routine steps before procedure, the actual procedure, and then the routine steps after procedure. Appendix J will be sterile dressing change for a midline and PICC line. Since these are the same, you will only need to demonstrate it once. So we have our standard routine steps before the procedure, as well as the routine steps after the procedure. Appendix K, doing a midline and PICC line flush. Obviously, again, the midline and PICC line are going to be flushed the same, so you'll only need to demonstrate this once. We have our routine steps before the procedure, we have the procedure, and then we have our routine steps after the procedure. So again, these checklists, this is what you'll be practicing with during your skill time, as well as this is what will be used to evaluate your skills during checkout. Appendix L, this is just going to demonstrate your instructor who will be checking your practice time off in the skills lab will be going through this and they will be signing off on it to show that you did have evidence of practicing. Appendix M, this again is going to be your clinical experience documentation sheet. I have referenced it before. This is what you're going to be doing at your facility after you complete this class. So you will need to have 3 IV starts with the signature of your preceptor RN, their license number, and the date that you were able to do it. You'll need to change a fluid container or your IV solution 3 times, again with the RN preceptor signature and their license number and date, as well as with the administration of IV antibiotic via piggyback, changing tubing, converting an IV to peripheral lock or inserting a peripheral lock. You'll also need to demonstrate sterile dressing change for a midline and PICC line. You need to just, either or is fine. You don't have to do 3 of each. Same thing with the midline and PICC line flush. You only need to do it for one of them 3 times. Once this documentation is completed, you will need to send that information back to me, Iowa Western. You can fax it, you can email it, but definitely make a copy of the sheet for yourself and your records before you send me the information. Your facility will also need to keep a copy of this on file with your documentation of completion of the course. This concludes Unit 5.